incredibly difficult. The constant fight, day after day after day. It's tiring. I'm tired. At times, I've wanted to give up the responsibility, the heavy weight of it all, to live for just myself again. Have you ever felt this way? But this is what I'm learning. I cannot separate myself from this work. It's interwoven into the fabric of who I am. It's what I'm made for. I see you, and I'm starting to see me.
I'm not a stranger to the dark. Hide away, they say, 'cause we don't want your broken parts. I've learned to be ashamed of all my scars. Run away, they say, no one will love you as you are. But I won't let them break me down to dust. I know that there's a place for us, for we are glorious. When the sharpest words wanna cut me down, I'm gonna stand up blind, gonna drown them out. I am brave, I am bruised, I am who I'm meant to be. This is me, look out, 'cause here I come. And I'm marching on to the beat I drum. I'm not scared to be seen, I make no apologies. This is me, oh, 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 oh. Another round of bullets ease my skin. So far away, just today, I won't let the strength sink in. We are bursting through the barricade and reaching for the sun. Yeah, that's who we become.
Yeah, that's what we become. I won't let them break me down to dust. I know that there's a place for us. For we are glorious. When the darkness burn, wanna break me down. Hey, hey, hey.
Wanna see the blood, wanna drown them out.
Hey, hey, hey. I'm meant to be, this is me. Look out, 'cause here I come. Hey, hey, hey.
And I'm marching up to the beat I drum.
Hey, hey, hey.
I stay TBC,
I make no apologies. This is me. Oh, 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 oh. This is me. Oh,
and I know that this doesn't when the sharpest words wanna cut me down, I'm gonna send a flag, gonna drown them out. This is brave, this is Bruce, this is who I'm meant to be. This is me.
look out, 'cause here I come.
Here I
Whenever the words wanna break me down,
I'm gonna drown
this is me.
I was having so much fun, I forgot, oh, I have to go up and speak next. So thank you so much, ladies and Fred. They are woohoo! They are with the Youth Compton Choir, and just incredible. I had the very fortunate opportunity of spending some time with them this morning, and I hope that you can grab them after this plenary and just talk with them a bit. Incredible people. So welcome to our 2025 SUD conference. So glad you are all here. Every single seat is going to be packed, and so I can see people in the back, and nobody likes this, but there are seats up front here. So feel free to mosey your way on up. Lots of empty seats right here up front. And so as we begin this event, we really want to start also with a land acknowledgement, that we acknowledge that the land on which we are gathered is home and traditional lands belonging to the Tongva Nation. Today we come with respect and gratitude for the Tongva people who consider themselves the caretakers of this land. It is through their examples that we are reminded of our greater responsibilities to take care of our earth and to take care of each other. Sorry, it was blurry. I realized I had my wrong glasses on. So anyway, I can see my notes now. So before we get too far into our program this morning, my team always gives me about 20 pages of housekeeping notes, so bear with me for a moment. But first and foremost, our workshops are going to be held both here and also at the Hyatt. And so you're going to find all that information on the locations of your workshops in your program guide. If you're like me, I like that old-fashioned paper. But we also have a new conference app. And so if you have right here, if you haven't already, you can download the app. And so my team is just so excited. And so hats off to Javon and Tyler. They were the real big pushers of the app. Woohoo! Go Javon, Tyler. And so it has, you can create your own personalized schedules. You can see floor plans. Let's see what else you can do here. Access the session materials. Oh, and there's even a game. Is anybody surprised? But there is a game. And so if you play the game, you could win a free entry to next year's conference. And so, spoiler alert, next year's conference is here back in Long Beach. So if you're interested, play the game there. And so if you don't have the app yet, the QR code is up on the screens, but it's also in the program guide. And we have another game that we love to play is bingo. So hopefully you received your bingo card when you came in. I've had a few people already be able to mark something off on their card because they complimented my dress. So if you feel the need to compliment my dress, then you can mark that one off. That's like a freebie. So feel free. Thank you. Yes, thank you. But I would like it personally face-to-face. So you got to be a little closer than that to mark that off. And so be sure to complete these cards by 4:30 on Wednesday. And then you can drop those off at the registration desk. And then we will draw the lucky winner on Thursday. And then some of you are here today. Maybe you are just here for the CEUs. That's fine. It's not going to hurt my feelings. But we do have those available for you. And so in order to receive those, just be sure that you're scanned in with your name badge into each of the sessions. And very importantly, that you're scanned out. And so if you don't get that scan, we don't know that you left and we think you're maybe still here at the conference. So it's very important to get that scan out. But if for some reason you missed your scan, you can go to the registration desk and they can help you as well. Don't worry, I only have 3 more hours of announcements. Whoopsie. Oh, this one's really important. Lunch. Woohoo! So both of the lunches are going to be served over at the Hyatt. And if you have been here before, the food is delicious. And so there's going to be lots of different places to sit. There will be folks directing you. So they will just move you on over to lunch, whether you are here at the workshops after this session or if you're over at the Hyatt at those workshops there. And last year we had our first wellness room and it was so popular. We have 2 this year. And so we have one here on site in room 204. And that is going to be our relaxation space. So if you need a little relaxing, there's some activities there for you. And then over at the Hyatt in the Beacon Rotunda, there's going to be some craft projects and some fun activities. So either if you're feeling like relaxing over here, over there, doing something fun, or do both. So those will be available. And then tonight we have our reception. And yes, we have the cheese. I was so excited. Oh my gosh. If you haven't had the cheese yet, I always talk about the cheese. The cheese is so good. But it's back. Chef Jill, I met with her last night. Like, you have the cheese, right? She got the cheese, Marlies. Everything's fine. So there will be many delectable things as well, but it's your opportunity to just connect, network, and we do have some fun activities there as well. We will, of course, have the photo booth. So if you're looking for DHCS staff, we're probably at the photo booth because we usually go home with 30 to 40 pictures each. So, and all right, so with that, that is the end of my housekeeping announcements. And my team, I should get an A+. Denise, I read every single one. I don't tend to do that every year. Sometimes I'm like, just kind of wing it. So I think I got through them all. And what I'm going to announce next is really, really exciting. Last year, we showed you a video on our Behavioral Health Continuum Infrastructure Program. And I know we had a lot of folks really enjoy that. And before we show you the update video, I want you to do something for me if you don't mind. I would love it if you have received a B-CHIP award, whether you work at a facility or maybe you're the CEO or anything in between. Could you stand up? Because I just want to show, and whether that is in our B-CHIPs round 3, 4, or 5, or our bond round 1, if you could stand up. Awesome. Thank you so much. So everyone that just stood up is either smiling or really tired because they have been working super hard, or they're smiling and tired. And so also they may be somebody that you want to talk to because we do have our round 2 open. So if you want to get some tips and pointers. But next we're going to just show you this video to show you the progress that they've all been making.
This is the most exciting work that's happening in the United States of America on mental health and substance abuse and behavioral health reforms. Period, full stop.
When I read through the grant, it felt like a miracle.
Prior to the grant, it felt like we were in an impossible uphill climb. We know what needs to be done, we just haven't the resources.
And so we're really excited about the grant that we received.
We will be building a facility that will hopefully take care of many of the needs of the people in our community.
Sorry, it's years and years of work. $93,760,044.20.
This new 16-bed adolescent substance use disorder residential facility at the Upland campus is more than just a building.
This project is designed not only to provide safe and stable housing, but also to offer critical services.
This is going to serve a lot of people and do a lot of incredible good for the community.
We know that recovery is possible, and it's why I'm so honored and hopeful to join you here today.
The new construction is going to allow us to increase the amount of residential alcohol drug treatment service beds.
This groundbreaking ceremony represents a monumental step forward in California's work to expand access to behavioral health services. Thanks to BCHIP, trusted community providers finally have the facilities and resources they need to provide essential services across the continuum of care.
What we're going to be doing is building out a 10-seat partial hospitalization program to support kids that would otherwise languish in emergency departments because there is no place for treatment.
So we're really excited to cover traditional healing services for our American Indian communities in California with substance use disorder.
3, 2.
We're flooded the zone in terms of support and resources. We've flooded the zone in terms of reforms as it relates to zoning and land use. We've answered every single call, including ongoing funding.
If it wasn't for these funds, this center, in which will serve thousands of individuals, would not be possible.
Don't we get to do rewarding things in our work? You know, waking up every day saying we're making a difference. And today, this is one of those days to celebrate and remind yourself, this is why I do this work, because you are really making a difference.
This is a really pivotal time in California's mental health history, and no more excuses, time to deliver.
Good morning, everyone. Paula Wilhelm, I'm the Deputy Director for Behavioral Health at the Department of Healthcare Services. Really excited to be back at this year's conference and excited to sit with special colleagues and share a panel discussion on behavioral health transformation with you all. So just briefly, I think you've already heard from Marlise today. She needs no introduction, but want to acknowledge that Marlise is the chief of our Community Services Division at DHCS. She leads and has led in her time at DHCS an array of substance use disorder projects. Her division currently administers our SAMHSA grants and also has branched out to become experts in infrastructure and behavioral health treatment and housing with programs like the Behavioral Health Continuum Infrastructure Program and Behavioral Health Bridge Housing. Critically, Marlise is also our project executive for Behavioral Health Transformation, or Proposition 1, which we're about to discuss, and is indispensable in that role, as I think you'll hear as she starts to tell us about some of that work. So very happy to share the stage with Marlise. I also have Tyler Sadwith, who is currently our state Medicaid director and has been in that role for about a year and a half, but previously at DHCS was the deputy director for behavioral health and began as an assistant deputy director for behavioral health, so has been in on the ground floor of a lot of our exciting reforms over the past 2 to 4 years at the state. Prior to that, also was a technical assistance expert across an array of policy areas, and some of you may remember worked for our federal partners at the Centers for Medicare and Medicaid Services during the time that California was launching the Drug Medi-Cal Organized Delivery System. So has been a recurring presence at this conference. And I will say that in Tyler and Marlise, we have both two incredibly effective executives and policymakers, but also incredibly passionate advocates who, again, I am proud to work with and lead this conversation today. So welcome, Tyler and Marlise. As mentioned, the focus of our discussion for the next 50 minutes or so is going to be what we refer to as behavioral health transformation. That is the package of legislation that was enacted by California voters in the spring of 2024 and includes the Behavioral Health Services Act and also the latest rounds of bond funding to develop behavioral health infrastructure and continue and grow the behavioral health continuum infrastructure program that was just featured in the video. So we refer to this package enacted as Prop 1 as behavioral health transformation. And really excited to talk with you this morning about some status updates for implementation. But also, I'm going to ask Tyler and Marlise to really get into the why of it all and talk a little bit about what we hope to accomplish with behavioral health transformation and why we think this work is so transformational and significant. So I'm going to do just a little bit of scene setting and a few updates, and then we'll turn to our panelists. Speaking just for a moment to the need for expansion of services and our behavioral health and substance use disorder continuum of care, I think many of you are familiar with these numbers. You do this work every day, but want to acknowledge that as many as 82% of Californians experiencing homelessness report having a mental health condition. And we know that 1 in 10 Californians likely meet clinical criteria for having a substance use disorder. We also know that more than 1.2 million adults in California live with serious mental illness, and 1 in 13 children has a significant mental health need as well. So our state leaders have long acknowledged that we really need to expand behavioral health treatment sites and resources and ensure we have a comprehensive continuum of both behavioral health treatment and housing options to help ensure that people with behavioral health needs can live safely and affordably in the community and access the types of supports they need. So as mentioned, the package of behavioral health and housing policy changes and investments that we refer to as behavioral health transformation was really developed to drive improvements in access to behavioral health care and access to housing for Californians with behavioral health needs, while also increasing transparency and accountability across all state partners that do this work. So the state, our county behavioral health agencies, our service providers, and of course, engaging members of the community and consumers of our behavioral health services. This was initially launched in the legislature under 2 different bill numbers. So we had Senate Bill 326, Assembly Bill 531 that passed in 2023, moved to the ballot in 2024, and was passed by California voters. DHCS and many of you and the community have really hit the ground running since the passage of Proposition 1 to begin developing guidance and moving toward changes, a lot of which will take effect in July of 2026. So one key piece of the transformation that you'll hear us focus on today is the move toward a more integrated approach to planning, funding, and delivering behavioral health or mental health and substance use disorder services. So when we converted the Mental Health Services Act to the Behavioral Health Services Act, the legislature and California voters were really recognizing that people are complex, mental health needs are often entwined with substance use, and ideally, our healthcare delivery systems should enable us to treat the whole person and a spectrum of behavioral health needs. As we'll discuss today, our county behavioral health agencies are now required to develop integrated plans that describe the array of behavioral health services they will fund and administer, inclusive of substance use services as well as mental health. And our Behavioral Health Services Act explicitly permits the use of behavioral health services funds for substance use disorder services as well as for mental health. So in the past months, in 2024 and 2025, DHCS has worked to begin implementing the required changes in the new policy, develop our data systems so that we can support the work that needs to be done, and also, of course, begin to disseminate the bond funds, the exciting part with the ribbon cuttings, etc. So we have conducted extensive stakeholder engagement on these policies. You may recall that in December 2024, we began to release draft modules of the BHSA policy manual, and that is really intended to be a one-stop shop of guidance for counties, providers, and the community to describe how the Behavioral Health Services Act requires us to spend these funds. Wanted to note that we have received and considered and integrated over 2,500 public comments through 3 comment periods on this core guidance, and begin to release the final policy guidance in February. And most recently in June, we released a 3rd package of updates to the policy manual that included that integrated plan template. Many of you know that the integrated plan is the comprehensive description that each county will develop in consultation with stakeholders to lay out how they intend to spend their array of behavioral health funds over a 3-year period. So pivoting a little bit, we also wanted to highlight for this audience one of our IT innovations, and that is our new licensing and certification portal. So in early 2025, we began to pilot the portal with a small group of users. Right now, this is a digital platform that can be used to manage licensing and certification for our SUD provider community. And current function is to facilitate the renewal of licenses and certifications across the state and to enable providers to pay fees online. We're going to continue to iterate and develop the portal so that it can process amendments to licensure and certification applications, and also enable providers to submit an initial application for a new program and see that through a completely new online platform and process. And this was really meant to be responsive to long-standing feedback that our licensing and certification processes are complex and take some time, and we want to find efficiencies where we can. So finally, we'll mention one more IT innovation. This is the county portal, which we just launched on August 6th. As many of you know, this will be an online platform for counties to submit their integrated plan data, and excited to have that open. We know counties have the planning process underway in many cases, and we are also looking forward to providing technical assistance as counties work towards submitting a draft implementation plan on March 31st of 2026. And so before I pivot to Marlise and Tyler, you already, I think, saw the impact of the bond funding and what we've been able to do with the Behavioral Health Continuum Infrastructure Program, or BCHIP, as we like to refer to it. I think that video did a fantastic job at capturing the way these funds have reached into communities across the state and created new opportunities to expand treatment. Specifically wanted to acknowledge that the bond infused up to $4.4 billion into the BCHIP program, and really are administering these funds as rapidly as we can through a competitive grant process. We have announced the first round of awards in Bond BCHIP Round 1. So back in May, we announced up to $3.3 billion in grants. And specifically that round 1, which we referred to as launch-ready projects, will fund 122 projects. And in those 122 projects, that will be 209 mental health and/or SUD facilities, so 122 residential facilities and 87 outpatient facilities. This is really kind of a monumental and rapid increase in the capacity across the state. Thank you. And a huge shout out to the teams in the room from DHCS and at the provider and county level who have submitted these applications, who are working to bring this infrastructure online. I will also note that with these Round 1 awards, the total across all of our BCHIP rounds is 377 projects awarded for funding 432 facilities, 215 outpatient, and 217 residential. So we did not pause after that round of awards. We immediately opened a round 2 back in May, and we anticipate awarding another $800 million roughly statewide. And in this round, we're really going to focus on what we refer to as unmet needs. So ideally distributing these funds potentially to rural or remote areas with particularly outstanding behavioral health needs or insufficient infrastructure. We're also looking at opportunities to fund regional collaborations and to move funding to geographic areas that haven't had BCHIP awards in the past. So just noting the deadline for application for round 2 is October 28th, and imagine many of you in the room may be engaged on that. So with that whirlwind tour of some recent highlights and milestones, I'm going to pivot and pass the mic to Marlise and Tyler to get into a little bit more of both the what and the why for behavioral health transformation. And we heard from the governor in the BCHIP video. I have another quote from him that we wanted to use to kick off this discussion. So Governor Newsom has publicly stated that the behavioral health transformation is, quote, the most exciting thing I have ever been a part of because it touches more people in more ways on more days. Can each of you describe what makes behavioral health transformation such a historic initiative? And I'm going to start with you, Tyler, and go to Marlise.
Thank you, Paula, and good morning, everybody. And first of all, thank you to the DHCS team for setting up this conference. Thank you to all of you for coming, because if it weren't for you, we wouldn't be here. You know, the behavioral health transformation is, I think, historic in a couple ways. I mean, not to sort of continue the drumbeat unnecessarily, but you know, that video we just watched represents about $3.3 billion getting out the door in about a span of 12 months. Is that more or less accurate? That's historic. I think the governor, we didn't have a quote from him on this, but in his budget plan presentation, noted sort of the historic, unprecedented nature of that much amount of funding getting out the door for projects, for development, for real estate acquisition. It's no easy feat to do this, as all of you know, because you've been busy planning and expanding your own facilities. It's extremely complex. And the fact that we are building brick and mortar capacity at this rate, at this scale, at this speed, in and of itself is historic. When I think about other aspects of behavioral health transformation and how it's historic, I sort of like to think about history and go back in time a little bit. What SB 326 does, one of the two bills that constitute behavioral health transformation, what it does in effect is it modernizes the Mental Health Services Act. And for many of you in this room, you might know this like the back of your hand. You can check out. But if you don't know the MHSA program, it started in 2004 as a voter approved initiative to tax personal income above $1 million at 1%. And that funding goes directly to providing mental health care for Californians above and beyond what their insurance might cover. That's a pretty strong program. That's a pretty strong statement on what our values are here in California. And since 2004, the MHSA has really been sort of a backbone of the behavioral health delivery system in our state. It's one of the key pillars of funding. It sort of forms a three-legged stool. You have MHSA funding, you have realignment funding, and you have federal funding through Medi-Cal that together comprise the vast majority of how county behavioral health care is delivered. And for the past 2 decades, we've sort of been a pace car state. I think other states have looked to us with envy because it's a really amazing policy and a really amazing program. And what BHT does is it recognizes that, MHSA has amazing strengths, and it was past 20 years ago. And in the past 20 years, our needs have changed, and there's an opportunity to strengthen and to modernize the MHSA program. And one way we are modernizing that is by adding substance use disorder into the picture. So under MHSA, it was really mental health centered, and substance use disorder care was only available if it was, co-occurring. So primary substance use disorder treatment was not allowed. Under BHSA, that's no longer the case. And so substance use disorder is given equal footing. But BHSA does a lot more than change, the M for mental health to the B into behavioral health. It goes a long way to not just reform MHSA as a program, but to take a step back and reform the entire behavioral health landscape and how this funding source works in concert with other programs and other funding sources. So we'll talk about this, a little bit later on, but BHSA is, pretty significant because it sort of drives on strategic alignment and priorities across this funding stream, across Medi-Cal funding, across county behavioral health, across Medi-Cal managed care plans, across county public health, really taking these systems, these service systems, these funding programs that for the past 20 years have been a little siloed, a little fragmented, maybe incongruent, and bringing them together, knitting them together so that they are working in tandem and in collaboration, driving towards the same behavioral health goals, the same behavioral health measures. So it's sort of all oars rowing in the same direction across programs, across systems, really for the first time. And I think that's pretty significant. And the last thing I'll say, and we'll touch on this in just a moment, is there's a lot more emphasis on transparency and accountability. For the past 20 years, we as a state, as residents of California, whatever administration is elected, who's ever in the legislature, no one has had a really good, insight granularly into how MHSA dollars are spent and what's purchased with them. Who's getting services? How many people? What services are they getting? What are the outcomes for those services? We have not had good data on that for the past 20 years. And so BHSA places a really strong emphasis on having all of us collectively in California just have better insight, better visibility into what care is being provided.
Marlise?
Great. I got to follow him. I'm the humor in this trio. So, and it's okay if you don't laugh. I laugh anyway. So I like to call BHT the gluten. I've been in this field. I started in 2001, and we've done some phenomenal work in multiple spaces, like Tyler's talked about, in policy spaces and different areas that we have lifted up together. And what I seem to be getting louder, so I'll hold my mic over here. No, what Tyler talking about, not only are we going to have this viewpoint in to help us at the state, really see what's happening in mental health and SUD, but also to give the public and others a view into what we're doing at the state. And we're going to talk a little bit about that, of how we're doing some things differently at the state as well. I think another really big part of BHT is one of the buckets, the components, is 30% for housing services, and recognizing that individuals, a lot of the folks that we serve after their treatment maybe need somewhere to live, whether it's an interim setting or a permanent supportive housing, and having that dedicated funding toward that is really, really exciting. And for our field here in SUD, including recovery housing and things that we have talked about for years, and that stable funding source behind that. And then also just really throughout BHT, and you'll see it if you've been following along or providing us with your feedback around evidence-based care. Evidence-based care and community-defined evidence-based practices are really big pillars We are a very diverse state, and we are serving so many different cultures and languages, and we need to serve them in the way that they need to be served. And so really infusing those, and you'll see we have in our full service partnerships, and there's a workshop on this in the BHT track, a little plug for this, around a new evidence-based practice, SUD field integration, and just really reaching folks where they're at. And so really I look at BHT as some combined wisdom that we've all shared together over many years collectively, and just bringing it all together. That's the gluten. And bringing that together in a way that really has the heart and soul of what we're all here for, is for the people we're serving. And so it's such an exciting time for us to be just lifting this all up with all of you, and we'll get into more of the details later, and there's a lot of information on our website. And yes, we're always pushing forward here in California, but this is such a way of bringing it together. So we really are super excited about it. There's a lot more we're going to talk to you about in this panel, and of course this is just the beginning. We're out of the starting blocks and moving forward, but this is going to be a transformative effort that's going to be rolling out for years to come.
Thank you. Thank you both for passionately and concisely capturing why this is so significant, and what some of the statewide impacts are going to be. Going to build on that question and go in a slightly different direction, which is just to ask a little bit about why the work is so important to you individually and what drives you to do this. And I'll share briefly that at this conference last year, I got to help open and talked a little bit about my background, and in fact that my introduction to doing this work really was meeting people who are working in substance use disorder treatment and participating in a project at the time that we rolled out the Drug Medi-Cal Organized Delivery System, and just being enveloped and sucked in the best way in the passion that the people in this room have for the work you do, and recognizing that this is a unique policy area and a unique opportunity to build and strengthen and further substance use services in California. I really haven't looked back from that, and I feel that the behavioral health transformation is the next rung on the ladder, and sort of incomparable opening of the policy window to do more and do this better and do this in new ways. So personally very invested in what we're working to accomplish here, and would just love to hear what that means to both of you, and maybe starting with Marlise this time.
Yeah, so there's a lot that drives me to do this work, and rather recently, I found out that my father's mother, she had schizophrenia, and in World War II, she was at an institution and she was murdered. And so my dad was really young. He was maybe 2 or 3 and became an immigrant into Germany because they lived in Prussia at the time. And so he never grew up really knowing his mom. And I also have learned just about the same time that my great-grandmother on my mom's side, she suffered from severe anxiety and depression. She also went into care in San Francisco, but unlike my grandmother, she had a supportive family. Her family all took some of her children and raised them for a while she was receiving care, and then she came back into her family. And this great-grandma, Van, lived in San Francisco her whole life. During the Depression, she felt that, nobody deserved to go hungry. So even though it upset her neighbors, she would provide a hot meal to anybody that would come to her doorstep. And I look at that, and that transferred to my grandma, who lived her whole life in San Francisco. And when I was growing up, we'd go to McDonald's, and she would know all the homeless people by name. She'd bring them coffee. She'd put out bags of food. She'd introduce me to the street workers and ask them how their kids were. And she really taught me that everybody has value and everybody should be treated with dignity and respect. And so I look at these two women in my life, one that I never got to meet, and how her disease was treated with stigma and shame. And then my other woman in my life that was surrounded by love and got the care that she needed, and that helped shape me for who I am today. And so just as I spoke this morning, that I feel like this work is interwoven into who I am because of both of these women.
Maybe I'll try something maybe that Marlies and Paula weren't expecting, but maybe if any of you have lived experience with substance use disorder, or you have a family member, a loved one, or a close friend who has struggled with addiction, would you do me a favor and just stand up right now? It's a nice stretch break. So a little bit of a sample bias because we're at the SUD conference. But, you know, yeah, I am just like everyone else in this room. And through personal and through family experiences, I've seen, the pain and the tragedy and the despair of addiction. And I've also seen the beauty of recovery. And that's why I keep coming back.
Thank you. And Tyler, I'm going to keep the spotlight on you for a minute and pivot to talking a little bit more about some of the policies that we're implementing within the behavioral health transformation package. You have said that this is an opportunity for DHCS to rethink how we implement policies successfully. I will add that not only was this package incredibly ambitious, it came with very ambitious timelines, right? We are have our moment and our policy window, and we are not sitting and waiting for change. We are trying to drive that forward. So wondering if you can talk a little bit about how we're approaching this project differently and what we hope to accomplish by that.
Yeah, I think it's a little bit of something I mentioned earlier, which is behavioral health transformation takes a step back and it looks at the behavioral health service delivery landscape in California, the publicly funded behavioral health delivery landscape globally and holistically. And it has, policy elements and funding elements that are designed to improve the performance of that entire service delivery landscape so that people can get the help that they need that matches their need no matter sort of what door they walk into. And it knits together these different systems in a way that is designed to coordinate local planning, drive collaborative transformation, and really optimize resources so that we can maximize the amount of funding available to provide healthcare. So just sort of one example that I just want to lift up because I think it helps sort of illuminate a little bit about how we're approaching this differently. Historically, Medi-Cal managed care plans have had to complete what's called a population needs assessment. And this is where they take stock of their entire enrolled membership and identify what are the needs of this population, who's at risk, how do I sort of reach out to those individuals most at risk, and how do I develop plan level programming to meet the needs of the population. Separately, local health jurisdictions, county public health, similarly conducted community health assessments where they took stock of everyone living in the community and said, what are the biggest needs? What are the health needs, the health risks of this community? And then they use those community health assessments to develop community health improvement plans to say and articulate, these are the strategies I'm putting in place, as a public health authority to meet the needs of the community. Two separate processes, two separate systems covering the same people. It's just duplicative and redundant. And so in CalAIM, we disbanded the population needs assessment as a standalone separate process, and instead we integrated that work into public health's work where they did community health assessments. So now Medi-Cal managed care plans, contribute, they participate in that public health process, they sit on the governance board, they provide data, they provide financial support, and they use that work to inform their population health strategy. Meanwhile, under MHSA, county behavioral health agencies developed three-year expenditure plans where they said, for the next 3 years, this is how I'm going to spend my MHSA money. And there's a community planning process that involves lots of different stakeholders. And that was entirely separate, for the most part. It was separate and siloed from what the plans were doing and what public health was doing. So under BHT, we are weaving that planning process into the coordinated efforts with the Medi-Cal managed care plans and county public health. And the goal is simply for the left hand to know what the right hand is doing, and for these entities who are responsible for separate service systems that all touch the same people to have better coordination and better collaboration so that we are sort of all rowing in the same direction. I think that's just one example of, how BHT is interwoven and there's strategic alignment and synergy across a lot of different funding streams, a lot of different programs that historically have been fragmented and siloed.
Thank you. Pivoting to Marlise, I want to talk a little bit more about the bond and wondering if you can share your thoughts about how the bond is transforming the field and talk a little bit about where DHCS is right now in implementing the program and just anything you want to add to stitch together the ideas that we got from the video and some of the numbers that I shared at the top.
Great. Thanks, Paula. Yeah, so the bond is one of my babies. Oh my gosh, they let me work on this. It is so much fun. Just getting to see all the applications, what you folks have put together, really just seeing across California from like mom and pops into larger campus models and working in and just really bringing what we've seen locally, what the needs have been, and to be able to, really start seeing we have I think it's now about 15 facilities that are actually open and providing services across the state, and more open each month. And I get to go out every once in a while because they keep me pretty busy with the rest of BHT, but just to see and meet the folks that are being served and in the bricks and mortar. It's literally, we're buying the bricks and the mortar and you guys are stitching them all together out there, which is fantastic. And we're going to keep seeing this move over the next few years because it is aggressive. The timelines are aggressive, and we need the capacity. And so while that is ridiculously exciting, at the same time as Paula just mentioned, we are finally having, bringing our SUD field into the latest century by getting out of paper applications for facilities. And even as we were working on the legislation, we kept being asked at the department, well, how many facilities do we have, Marlise? And I'm like, well, I can tell you we have this, and we have this, and we may have that, and we may have this. And they're like, no, give me the bottom line. I'm like, I can't. And, it's a little embarrassing that we haven't been able to have our system automated. And so just Paula talking today, and I know some of you were some of our test providers, and if you haven't interacted with our new licensing portal yet, you will. We do have 2 workshops here, another shameless plugs, one on the county portal and one on the licensing portal. But to be able to bring that level of just the technology to help ultimately our providers spend less time in the back and forth, our review processes, like to really bring the transformation not just in policies and with the bricks and mortar, but to actually what's happening in those facilities, not only the ones that we're constructing with the bond, but for all of our facilities. And so BHT lets us, and the bond, yes. So maybe you haven't received a grant yet, but you are going to receive the impacts of those grants, even just through the licensing portal itself. And so it's really, really exciting to see what we're able to do to improve our field as a whole. And the bond just gives us a phenomenal opportunity. And the only other thing I'd want to say about the bond, and I had a really fortunate opportunity, a career opportunity to get to present this to the governor back in May. And I got to tell you, that was one of the most difficult presentations I've ever done. And not because he's the governor, but I walked in and he says, "I've already seen your presentation. I've already looked at all the slides." And I was like, oh, crap. Like, that's what I've been rehearsing for hours. And he's sitting at his desk and he's like looking at me and he's like, "I have a lot of questions for you." I'm like, okay. And he just had these amazing questions and difficult questions. And the most challenging question he had for me 3 times that he'd stared at me and said, "So I just have to trust you." And I was like, yes. Like, he's like, "I'm sure you know what you're doing, the clinical need and da-da-da-da, but I have to trust you." And I'm like, yes. Because he cares so much about it. He can't stop talking about it, like Tyler said in the budget. But that's like BCHIP has that effect on. Like, people are so excited. Other states are so excited. Other states want to model after us. Like, we are just once again at the forefront pushing things forward. And the bond, I like to say, is the first one at the start of the parade with BHT. There's so much more of this parade yet to come, but the bond is just out there and shiny, and you all are making it happen. So it's super, super exciting about that, and changing in so many different ways, not only, like I said, the bricks and mortar, but in other spaces as well.
Thank you. And agree with your and the governor's reflection that often in the early stages of implementing new policy initiatives, it feels like a trust fall, right? We're all rolling out and taking those initial steps and not entirely sure where we're going to end up. And in a few minutes on this panel, we are going to talk about some of the work that is being done to look at outcomes over time with the Behavioral Health Services Act. So excited to get to that. But before we do, I want to dip back to something I also mentioned at the top, which is one of the changes that was included in the Behavioral Health Services Act is to make the act and the use of our behavioral health services funds more inclusive of substance use disorder services and the population of people who needs substance use care in addition to or alongside mental health services. So specifically, the BHSA explicitly permits the use of behavioral health services funds, which, as Tyler explained, initially the Mental Health Services Fund, our millionaire's tax, now can be used to support services for individuals with moderate to severe substance use disorder with or without the presence of a co-occurring mental health diagnosis. And additionally, we've been talking about integration and breaking down silos and the county integrated plans and the statewide population health goals and measures that we'll talk about are meant to be fully inclusive of behavioral health services, so SUD, as well as mental health. A really significant change in the way we approach the organization and financing of mental health and SUD services in California. So Tyler, I'm wondering if you can talk a little bit more about why this expanded and more inclusive view of SUD is significant, and perhaps some of the key policy innovations that we're pursuing under BHSA as it relates to SUD.
Awesome. The crown jewel of the panel. Yeah, so it's exciting. I think the reason why it's exciting to me is that, we know that behavioral health has often been the afterthought to medical care, right? We have a fragmented, carve out delivery system here in California and across the nation. The medical establishment, funding for research, et cetera. We've never really been prioritized in behavioral health. We know that's changing. We know now behavioral health is the topic du jour. Even within behavioral health, though, substance use disorder has often played second fiddle to mental health. Substance use disorder was the afterthought. It, got less oxygen than mental health. And the spending bears that out, right? We know that in Medi-Cal, about 15% of the dollars in county behavioral health go to substance use disorder. 85% goes to mental health. That's not to say that 50-50 is the right sort of split, but that just gives you a sense of where the resources go. MHSA for 2 decades, $0 for substance use disorder. So now we are now substance use disorder is in the picture, which is important. In the community planning process that each counties will use to develop their 3-year integrated plan, there's a requirement to include individuals with lived experience with SUD in that process. There's, references to, SUD providers and SUD stakeholders. There's a requirement that counties develop their 3-year plan based on local data, including unmet need, including substance use disorder prevalence, overdoses. There are statewide goals that counties are going to be aiming for. These goals include reductions in overdoses, increased access to substance use disorder services. So counties are, directed to incorporate substance use disorder planning into their BHSA plans in very prescribed ways. And there's a seat at the table for substance use disorder. So claim your seat. I'm excited about some other aspects of BHSA with respect to SUD. One of them is in the what's called the full service partnership component. Full service partnership historically has used what's called the do whatever it takes philosophy to meet individuals enrolled in their FSP program. It's been very flexible, rent, clothing, et cetera, along with intensive programming for serious mental illness. Now substance use disorder is called out in specific ways in FSP. One thing BHSA does is it modernizes FSP for mental health as well. Counties have been doing a great job with FSP, but it's sort of a black box and there's no standardization, and what's available in one county isn't available in another. Don't have great insight into FSP. And so what BHSA does is it requires counties for the mental health side to implement evidence-based practices like Marlise mentioned that are proven to improve outcomes for Californians experiencing the greatest inequities with most significant behavioral health conditions. Services like assertive community treatment, forensic assertive community treatment, individual placement and support, model of supported employment. These services are proven to help people with the greatest needs, the highest acuity, to stay out of the ED, stay out of jails, retain housing, have better quality of life. A lot of these services are based in the evidence, they're well established in the research literature, and they represent a paradigm shift where instead of expecting patients to come to the clinic and to show up at a medical facility and to sit there for a session at a prescribed time and to, follow the treatment plan and take the medication and just, get the medication dispensed at a pharmacy, right? That's a perfect patient. That's a unicorn patient. A lot of these services in FSP on the mental health side, like ACT, FACT, coordinated specialty care, these recognize that people are not unicorns. People have needs. People with the greatest needs require a lot of love and engagement and intensive touch. And so these models are field-based and they're assertive. They involve multidisciplinary teams going into the community and bringing the care to the people, where the people are. And so counties will be implementing all of this in FSP. What's really interesting is the field really doesn't have similar models for substance use disorder. But in the FSP section of BHSA, there's a requirement that counties develop similar, assertive, field-based treatment for substance use disorder. So this is like a really big opportunity for innovation and for counties and providers, for all of you in the room, to push the envelope and to create this. What does this look like? What does it look like to bring substance use disorder care into the field, into assertive, proactive outreach modalities? And this is not new. Many of you are doing this today, whether it's mobile NTPs or street medicine or, outreach programs. In Medi-Cal, we've aligned our policies, our payment policies, our coverage policies to support all of that, to continue to enable that. But in BHSA, we call that out explicitly. And there's, I think, a sort of creative development opportunity here in the state of California for us to maybe create some new models of care.
Thank you. So one of the principles that I think really underpinned the initial architecture of the BHSA as it was being developed, and continues to be something that you'll hear us talk about a lot, which is one goal is to increase transparency and accountability in the way that we organize, finance, and deliver behavioral health services. So I'm going to ask the two of you to expand on that transparency and accountability catchphrase that you'll hear us use, and talk a little bit more about what that means. I'm going to open by sharing that one of the components of the BHSA that I am personally most excited about is the development of a statewide population behavioral health strategy, including statewide goals to improve our behavioral health outcomes, and then a corresponding set of performance measures that we can track over time to measure our progress toward those goals. So some of the goals that have already been identified include reducing overdose, reducing untreated behavioral health conditions, and we really have moved into sort of the hard work of determining the best metrics to hold ourselves accountable. So Tyler, I'm going to pass to you first for your thoughts on the way we're updating and strengthening our approach to accountability, and then we'll go to Marlise.
Thanks, Paula. And before I dive into that, I want to mention one thing about the question that you asked previously, because it's going to keep me up at night if I don't say it. A lot of what you see in the sort of substance use disorder policy in BHSA is just in organic alignment with a lot of the work that Los Angeles County is doing around the Reaching the 95% initiative, and that a lot of other counties are doing as well. Sort of in alignment with that Reaching the 95% initiative. So just wanted to sort of shout that out, because it's just sort of a natural affinity where, really, really pushing us as a field to make sure that we are doing the outreach and, shaping our policies so that we're available to provide help to everyone who needs it, regardless if they're the unicorn patient or not.
And if you're not familiar with the Reaching the 95% initiative, I believe there is a panel during this conference. So check your conference program. Go on.
So accountability, a couple things come to mind. One is exactly what you just mentioned, Paula. It's a, behavioral health sort of quality measurement framework that's being enacted right now. And it's worth calling out. There's sort of two phases to this work. Phase one is the development of statewide population-level behavioral health measures. There are 14 of them. And these are measures that are useful to all of us as residents of California to better understand how are we doing as a state on meeting the needs and improving the lives of Californians with behavioral health conditions. The scope of this is not limited, not specific to county behavioral health. These measures are tracking things that a lot of partners are responsible for, including county behavioral health, county child welfare, county public health, education system, managed care plans, etc. So phase one is really statewide measures, state-level measures, population-level measures. Phase 2 is the really hard job of taking those statewide population level measures and translating them into measures and metrics that are useful to show how is any given county's behavioral health sort of agency doing? What are the opportunities for improvement? And by the way, how are the Medi-Cal managed care plans in that county doing? What are the opportunities for improvement there? So this set of statewide measures is really the North Star that's driving all of the programming, not just in BHSA, but it will be driving how we are treating and dealing with Medi-Cal managed care plans. It will be driving the programming around the California Department of Public Health and their use of prevention dollars under BHSA. It's really the point of convergence, the North Star that all systems are aiming to. I think one other item really is an annual report. The BOTR is an interesting acronym: Behavioral Health Outcomes, Accountability, and Transparency Report. All right, thumbs up from Marlies. The BOTR is going to be a product that will reveal and make available for the first time critical information about how, that global picture about what services are being provided, under realignment, under BHSA, under Medi-Cal. We're going to get a picture every single year of what care is being provided, what services are being purchased, and what do outcomes look like. So that's another really key sort of resource that's new under this initiative.
Great. And since Tyler took accountability, I'll take transparency. And so everything that Tyler's talking about and what we've talked about with the integrated plan and the BOTR, and I love saying BOTR, makes me so happy. What we have to do in order to show all of this and to show how our county partners are doing is we need to have the transparency on the data. And as most of us know in our field, our data, it's embarrassing. Our systems are archaic. And so a really big part of BHT, and I'm going to embarrass him right now, but is my partner in this effort is Ryan Mosley. He's over there, stand up there. So he, along with his team of incredibly smart IT wizards, just really a department and like Paula talked about earlier, just with some of the initial work with the licensing portal and the county portal, but we have other transformation that's going to be occurring with our data systems that we're really, really excited about. Because ultimately what we want to be able to do is collect that information that Tyler spoke about in a way that reduces duplication, reduces the silos of how we collect it, and really, once again, to get back to what you folks want to do is the patient care. And so we've been doing a lot of back-end work on just figuring this out as we're setting the policy, but then really looking at our legacy systems and really looking and seeing how can we do things differently. So we're really excited about that work, and with Ryan and his team. Is happening countywide, but then so you can too see at your level, if you're at a provider, of what's happening in my provider. So excited, and we're gonna need some time, and a lot to lift up, but we've really started these efforts in that sense to provide the transparency that we need to at the state and local level, so we can all just really make better decisions with this information. If we need to, change up policy or maybe something even locally you're doing, but to have those resources available for you. And with that, we need that information. So super exciting. That's a really big tenet of BHT as well.
All right. Thank you both. And thank you to our audience for coming along on the BH transformation journey with us this morning. I'm really hoping that you learned at least one new fun fact about the BHSA, if not 10 or 12 new fun facts, because we covered so much ground here. So I am going to close us out with kind of a lightning round. Where is DHCS going next with behavioral health transformation? Tyler.
One thing that we haven't touched on, which is top of mind for me, are the resources available and the tools that we are making available to help bring all this work about. I mean, we're talking about a lot of change management, a lot of new expansions, a lot of new policies. And we talked about, strategic alignment across programs. There's another program, a Medi-Cal waiver called BH Connect that really works in close concert with BHSA to provide resources and tools to counties and to providers to make this work. So one thing we're doing is we're collaborating with the Department of Healthcare Access and Information, HCI, to provide $1.9 billion in funding over the next 4 years to expand California's behavioral health workforce. This is a massive, massive, massive investment that is really designed to, expand the workforce, expands the supply, the diversity, people in care providing roles in the specialty behavioral health delivery system, including SUD providers. So please be on the lookout for opportunities from HCI for that, $1.9 billion in funding going to organizations, to individuals who want to pursue a behavioral health pathway. There's some other opportunities that I'm excited about for substance use disorder in particular with BHT that intertwine with BH Connect. BH Connect gives counties the opportunity to opt in and cover a lot of new services in Medi-Cal. These services are called out in BHSA and FSP. So services like ACT, coordinated specialty care. But there's two that come to mind for me for substance use disorder in particular. One is community health workers. Counties have the opportunity to cover community health worker services in Medi-Cal, including for substance use disorder, which provides funding for that outreach, that engagement, that sort of proactive reach out that historically could never be billed to Medi-Cal. The other opportunity that's new in Medi-Cal that intersects with BHSA is supported employment, including for substance use disorder. So counties have the opportunity to cover individual placement and support model of supported employment, including for substance use disorder. It's really exciting. It is really sort of a life-changing service that provides, dignity and sort of quality of life outcomes to people who get it. A lot of counties are making ground on the mental health side. It's also available for substance use disorder, and it's in BHSA as well. So I'm excited about that. Finally, and I know we're at time, the Centers of Excellence is another key resource that are available to providers and to counties to help with these new services. So across the state, there will be Centers of Excellence to help with implementing these new services, including supported employment. So I'm excited to see, how that provides TA and support to providers and to counties as we go along this journey.
Marlise, ready to close us out?
I know. Tyler and I could be up here for like 5 hours. I do also want to leave you, though, with we do have our first three for our policy manual, all the guidance our county partners need to develop their integrated plan. So I would encourage you, they're starting their stakeholder engagement activities. So if you haven't already, to connect with your county partners. We do have some resources online if you need help in figuring out how to do that, because they're entering their planning process. And it's not just for BHSA funds, it's for all their SAMHSA funds, opioid settlement funds, realignment, Medi-Cal. This plan covers all of the county behavioral health resources that they receive. And so really encourage you to do that. We're going to continue to be rolling out policy as well, and then gearing toward that first draft integrated plan that's going to be due to the department in March of 26. And really coupled with all of that is we are just throwing out there tons of training and technical assistance. Tyler just mentioned the Centers of Excellence around those evidence-based practices, but you need an infographic, we have it. I mean, we have tons of information. If there's anything that we talked about today that you're slightly interested in, it's on our website. More is coming. And because we really want to just surround all of you with the help that it's going to take to lift this up and roll this out. So we'll be continuing to be pouring that out. So keep looking at our website for more information, trainings, recording things. And we're going to continue to be rolling out more policy. We're going to have our Modular 4 coming out in the next few months about oversight and monitoring, and we'll be continuing to roll that as well. So I hope you learned a little bit today. We do have a workshop track on BHT, so where we go in depth, we're There's some great subject matter experts, and you can ask a lot of questions there. So, but back to you, Paula.
I will just say thank you both for your leadership and for the discussion today. And thank you to all of our participants for the part that you're playing in implementing this transformation for our behavioral health systems and for SUD treatment and services. Thank you all.